Hi, everybody. My name is Dr. John Schnorr, and I'm one of the reproductive endocrinologists here at Coastal Fertility, and I'm looking forward to meeting with you guys today. We are doing what we call Coastal Quickies, which is just a quick presentation on one of the topics of infertility. Recently, we did some topics which worked on infertility treatment options. We talked about evaluation, ovulation induction, and intrauterine insemination, in vitro fertilization, egg donation, egg freezing. We talked about all those things, and today we wanted to start going into some of the different topics of causes of infertility. And my topic today is going to be male factor infertility. So we have probably about 20 to 30 minutes today to discuss male factor infertility. At the end, I'm going to be able to take some questions and hopefully give you some answers along the way. And we'll be talking about all that while we go through things. We want to talk about the fact that male factor infertility is actually very, very common. There are very rational ways that we can work up and understand male factor infertility. We'll talk about all those, and we'll talk about some of the treatment options. Just as a background, I'm an OBGYN trained doctor who did an OBGYN residency at the University of Virginia in Charlottesville, Virginia. I then did a reproductive endocrinology fellowship, which is a fertility fellowship at the Jones Institute for Reproductive Medicine, which is in Norfolk, Virginia. That's where they had the first IVF baby with gonadotropins in the world, kind of very special place to be from. I've been here in Charleston now since 2001. I have a wonderful wife. Her name is Susan, and two daughters. And we love being here in Charleston and in South Carolina, and love being here with you guys today. I do have the pleasure of being the division director for reproductive endocrinology at MUSC, which I've been doing that since 2004 as their division director, and I also serve as the medical director here at Coastal Fertility. What we're going to do is talk a lot about male factor infertility. We're going to talk about the background, kind of the pathophysiology, really what causes it, the goals of the evaluation, kind of why we do the evaluation, what the workup causes, and we'll talk about some treatment options. We know that about 15% of all couples have infertility. We define infertility as 1 year of intercourse without a conception. Male factor infertility is probably present in upwards of 60% of those cases to some degree. Probably 20 to 30% of the time, the sole cause is male factor infertility, meaning that the female workup is totally normal. Probably 30 to 40% of the times, it's a contributing factor, meaning there might be another primary cause, but maybe there is a sperm count that's not quite optimum, and that might be kind of adding to some of the challenges. The goals of the evaluation, the reason we do the evaluation is we wanted to look for correctable causes. We want to make it better, the simpler and easier way. And we'll talk about what that is. We want to look for irreversible conditions that are amenable to other treatments, like in vitro fertilization, meaning we can't make the sperm count better, but we can get enough sperm that we can use it for IVF or for other things. There might be some irreversible conditions where we're not able to get any sperm at all. And then we talk about donor sperm use and adoption, which are very real, creditable options. We'll talk about the health implications of male factor infertility and some of the genetic abnormalities that can happen. When we think about the diagnosis of male factor infertility, we do it, of course, through a sperm count. When we count sperm, we have the ability to see how many sperm are present, how well they're swimming and moving, and we can understand the shapes of the sperm when we look under a microscope. We typically know that based upon national studies, greater than 15 million sperm per milliliter is the sperm concentration, which is thought to be normal. Most fertile men are probably in the 40 to 50 to 60 million range, but this is the low end of normal at 15 million. The percent moving is of the sperm that are there, how many can move. We want that to be greater than 40%. And we do have the ability to assess the morphology of sperm by looking under the microscope and understanding the shape of the sperm. We know the sperm shape can have some predictive ability for fertilization. For couples who have infertility, we like to go over your history to understand how long you've been trying to get pregnant. Have there been any prior pregnancies? Have you had pregnancies with the present partner or any prior partners? Have you had any treatment that's been successful or unsuccessful? Has there been any evaluation of the female side to see how that's doing? And we go over what we call sexual history, trying to understand, are you using lubricants? Are you able to have an erection? Are you able to ejaculate? How frequently are you having intercourse? Those are all things that are kind of pertinent to the history, and we kind of go over that. We also know that lubricants can be a challenge. And, one of the things I wanted to talk about today is that there are studies in the literature that show that the commercial lubricants that are available inhibit sperm motility, 60 to 100% decrease within 60 minutes of incubation with some of these lubricants. And so some lubricants are better than others. The national studies kind of look at pre-seed as probably being one of the better lubricants to use. You can generally buy that at a drugstore or at Amazon or another location. But typically KY, Astroglide, Replen, Surgilube probably causes a little bit of male factor infertility and would be recommended against using that. Again, I think pre-seed, and I don't have any financial relationship to them, but the studies show that pre-seed probably has some benefits by using it. Medical history, we like to go over a male's medical history to make sure that there aren't any systemic illnesses that are currently causing problems. Venereal infections can cause problems, so we like to review that. Mumps orchitis, which can cause inflammation within the testicle, and as a child can be a cause of antibodies and infertility. We like to look at a family history to see if there's any relatives that have male factor infertility, see if there's any genetic components of it. And we also know that cystic fibrosis can have some male factor infertility associated with it, so we would check into that. I'd like to go over a man's surgical history. Men can, as children, have problems with undescended testicles, which can cause male factor infertility. Testicular torsion can be a cause of male factor infertility where the testicle twists on itself. Testicular trauma can be a cause of male factor infertility. Testicular surgery, such as removal of a testicle, repair of a hernia, and sometimes pelvic surgery can be a cause of male factor infertility. Men who are exposed to chemicals and radiation could have infertility. For example, radiation and high thermal exposures, high temperatures can be a cause of male factor infertility. Chemical exposure can be. We like to go over any medications that a male has been on in the past or currently on. Includes chemotherapy, cimetidine, which is used for GI problems, sulfasalazine, alcohol, smoking, and marijuana, and then steroids. And we'll talk about steroids in a little while. Focusing on the things that are common, alcohol consumption, greater than 14 glasses of alcohol per week is thought to be associated with male factor infertility. Tobacco use is thought to be associated with male factor infertility. And the medical literature very much shows that marijuana use can be associated with male factor infertility. So if you had low sperm counts and used any of the three, the strong recommendation would be that you stop. Physical examination is generally also involved. Physical examination typically done by a urologist, a doctor who specializes in the male anatomy. It would include a rectal exam, checking the prostate and the seminal vesicles to make sure they're normal, checking the testes and the epididymis to make sure they're normal, make sure the tube that connects the testicle to the outside world called the vas deferens, make sure it's there. And then look for varicoceles. Varicoceles are varicose veins that can form in the scrotum that can cause male factor infertility. They can check for those to see if those are present. And there are some studies showing that surgeries may have some benefits in that regard. In regards to varicoceles, varicoceles are basically varicose veins in the scrotum and testicle. They can put pressure on the testicle and the veins. Most varicoceles are on the left side. 75 to 90% of varicoceles are on the left side. About 10% are on both sides. You can palpate them on both sides. Basically, it's a dilated venous system that kind of goes down the testicle. You kind of see it here, and then it can warm the testicle and decrease the testicle size and decrease sperm making within the testicle. And so there have been studies associating varicoceles with infertility. It's thought that if you look at the general incidence of a varicocele in the population, about 15% of all men have a varicocele, but interestingly, of all infertile men, about 30% have a varicocele. And so there is some association. We know that in a large study of 9,000 men with varicoceles, if a varicocele was present, about 25% of men had abnormal sperm counts. And so the incidence of men with normal sperm counts it was about 11% in men with varicoceles. So more than 80% of varicoceles are not associated with infertility. And that's very important, that there are a lot of men out there with varicoceles that actually don't have infertility. And so having a varicocele in and of itself is not the end of the world. But if you have male factor infertility and have a varicocele, the question quickly becomes, does surgery help? And I think the general conclusion is that surgery is able to increase the quality of sperm, but really not able to increase the quantity of sperm. So surgery can play a role. It can make it so that the sperm count doesn't get worse with time. Doing the surgery to repair a varicocele makes it so that the sperm count kind of plateaus, but doesn't necessarily increase the quantity of sperm that's present. Other things that we look at for men with male factor infertility is genetic testing. Of course, we're talking about using the sperm to help you conceive. If you have a genetic abnormality causing the male factor infertility, we would want to know about that because that could increase the risk of birth defects. And so one of the things we would measure is called a standard karyotype, counting the number of chromosomes in a male's body. Sometimes a male can have too many X chromosomes or too many Y chromosomes or other abnormalities that can be a cause of male factor infertility. There can be deletions on the Y chromosome, which is the region that's responsible for making sperm. And if there's deletions on the Y chromosome, we think that can be a cause of male factor infertility. And men with cystic fibrosis, not really men who are carriers, but men who actually have cystic fibrosis, are known to have often a blockage or removal of the vas deferens. So the vas deferens is not present, and therefore sperm can't get from the testicle out into the real world. And so it's kind of almost like a man with a vasectomy if you had cystic fibrosis. Then very correctable. We would just want to know about that so we know to correct for it. We often do testing, which is hormone testing for men with male factor infertility. Look and see if there's a hormonal cause that could be causing that. It's a good one to have because that's something we can correct a little bit more. And so if there's less than 10 million sperm per milliliter or maybe impaired sexual function or other problems, we would do male hormone testing. What we would test for is a byproduct of sperm making is testosterone. We would check a male's testosterone level. We would check his FSH and LH level to make sure that those are normal. Now, for men, we prefer to do blood testing for men in the morning. That's when men's hormone levels are the highest. And so typically between 8 and 10 a.m., a man would have his sperm count done, at which time we would measure those things we discussed: total testosterone, FSH, prolactin, estrogen, and thyroid would be typically the hormones that are tested. If we were to find deficiencies of the hormones, we could give you back those hormones and hopefully make the outcome better. Another area that really talk about is men who use steroids. Steroids meaning bodybuilding hormones like testosterone. It's common for men to have low testosterone levels and common for men to put themselves or have a doctor put them on hormones. And when they're put on testosterone can significantly decrease your sperm count. As a matter of fact, a lot of men on testosterone won't have any sperm at all. And it's due to the fact that the way your body knows if you're making sperm or not is it measures your testosterone level. And if you have a low testosterone level and you're not on hormones, your brain starts working harder to make more testosterone to make more sperm. If you have a low testosterone level and you give yourself testosterone, your brain figures out that you have plenty of sperm in your body and actually decreases sperm making, thinking you're probably making too much sperm. And so both intramuscular and transdermal testosterone can make the testicle smaller, can lower your FSH and LH, and increase your testosterone level to the point that you don't make any sperm at all. Now, for men who have low testosterone levels and want to get pregnant, a solution would be to not be taking testosterone, and instead we can give a man tablets of something called Clomid, also known as clomiphene citrate, or give them injections of a hormone called HCG. Clomid and HCG have a way of making it so that the testicle makes more sperm and makes more testosterone. And so it helps kind of get you to having a normal sperm count and a normal testosterone. We generally use urologists to help you monitor that to make sure that it's prescribed in the right dose and there aren't any side effects that would harm you along the way. Typically, Clomid is administered at 50 milligrams a day, which is 1 tablet a day. And HCG is injections that's generally done 2 to 3 times per week. HCG is a little bit more expensive, but more potent and often the better way to go. But we can certainly try simple with Clomid if you would like. Again, this is only indicated for men with low FSH and LH levels and men with low testosterone levels at the same time. So you need to have low levels, and we need to be trying to replace those levels. If you put a man with normal levels and low sperm counts on hormones, you tend not to improve outcome by doing that. What kind of treatments do we do for male factor infertility? This is a little humor added to the talk, which is basically a man in a full body cast and wife talking to the physician team asking, does this mean we have to put off our plans for natural conception? And, you know, even if your sperm count's low, we do think there's still a chance that you can get pregnant on your own. So we're never going to ask you to stop trying on your own. So always, by all means, continue to try on your own. The question is can we add any treatments that will improve outcomes? We talked a little bit about varicocele surgery. There may be a role for varicocele surgery, depends on the circumstances. If your testicles are smaller than normal, or one is smaller than normal, or you're having pain, or maybe the varicocele is particularly large, there may be a role for surgery, and we will defer to your urologist for that assessment and recommendation. For men with low sperm counts, as I mentioned, sometimes we can give them Clomid. This is typically for men who have low FSH and LH levels, and by giving you the hormones, your FSH and LH levels will rise. Generally, as a result, your body makes more testosterone, and then along the way, you start making more sperm. Some men may need injectable medications. That's at HCG or sometimes even FSH, depending on the abnormality. But if it's a hormonal cause, there are ways that we can fix that for you. Other treatments for men who have low sperm counts, we can talk about ovulation induction and intrauterine insemination. We're going to talk about that today. And of course, in vitro fertilization also becomes a good source of treatment. Intrauterine insemination is a process in which we can take the sperm and put it into the uterus. I'm going to show you a slide on that. It's generally only good for men with normal sperm counts or slightly low sperm counts. The number to remember is what we call the total motile sperm count, which is a way that we can figure out how many moving sperm are in the ejaculate. And so the way you understand the total motile sperm count is it's the volume of the ejaculate times the concentration times the motility. So kind of let's use simple math. Let's say you have 50 million sperm per milliliter and you have 2 milliliters in ejaculate. That's 100 million sperm. And then we'll say that 40% are swimming and moving. You would then have 40 million sperm that's available in the ejaculate. And we want it to be greater than 20 million for intrauterine insemination to have a good success rate. I'll show you our success rates by sperm count in just a second. The way intrauterine insemination is done is often your wife is put on medications, and sometimes even without medications. Sperm is concentrated into a catheter. We then put the catheter up into the uterus and can put the sperm into the top of the uterus. Takes about 2 minutes. Very simple, easy procedure. No real pain or discomfort associated with it. Sperm counts vary based upon the amount of sperm. This is the sperm count after the wash. And so I told you 20 million is the number to think about. About half of the sperm is taken out in the wash. That's part of that cleansing process, which means that if you start with 20 million sperm at the time of intrauterine insemination, you generally have 10 million sperm. And as you can see, our 2020 and first quarter 2021 results show about a 16% chance of pregnancy per IUI cycle with a normal sperm count. If you were to have a low sperm count, you can see here 5 to 10 million sperm, which generally means that you started with probably 10 million sperm to maybe 15 million sperm. You end up with a 10% chance of pregnancy per try, and less than 5 million sperm results in lower pregnancy rates than we really want for people. So again, this is after the wash. About half the sperm is taken out with the washing process. You can't do an insemination without the wash being done, and that's because there's prostaglandins in the ejaculate, which would cause intense uterine cramping if we didn't do the wash first. And so that's how that's done. I'm sure you've heard about in vitro fertilization. IVF is the ability to take eggs out of the ovary, fertilize them in a test tube, and later put embryos back in the uterus. Now, there's a very specific way that we can fertilize the eggs. I'm going to show that to you. But basically, this makes it so that you just need 1 sperm per egg. And so if you have 10 eggs, you literally just need about 10 sperm. Men who don't have sperm at all are called azoospermia. It's called azoospermia. And in those men, testicular surgery such as biopsies can be done to get the sperm out, and that can give us enough sperm that we can fertilize it. Pregnancy rate depends often on female age. If you've had a vasectomy before, we can get sperm out very easily and should have a high chance of having sperm at that time. IVF with male factor infertility is done by taking a small glass needle, like you can see here, and picking up one sperm and putting the sperm into the glass needle. And then that needle can be put into the egg, which you'll see in the next screen. Here's the needle all the way in the egg, and then the sperm is injected into the egg and the needle is then removed. This is a process we've done for almost 30 years now and has resulted in pregnancy rates almost the same as if there wasn't male factor infertility. It results in embryos, as you can see here. Here's embryos. The embryos can grow in the test tube and form blastocyst embryos, at which time an embryo can be transferred into the uterus. Very simple process. This is the national success rates from our national society called the Society for Assisted Reproductive Technologies. And the national success rates show us the pregnancy rates at the average IVF center. I like this graph a lot because it shows all the different types of infertility that we treat, and then helps us understand how male factor infertility fits into the pregnancy rate. So for example, if a woman has blocked fallopian tubes and you're doing IVF because of blocked fallopian tubes, the average pregnancy rate is 27.5%. The national pregnancy rate for male factor infertility, meaning it's a male cause of infertility, shows a 30% chance, 32% chance, which of course is much better, and showing us that male factor infertility is very readily treated and with good success rates with doing IVF and ICSI. What are our pregnancy rates? Our pregnancy rates are here. This is our most recent 2018 live birth rates. Coastal Fertility is here in the blue. The national average is in the red. You can see that we're proud that we outpace the national average. Our success rates and all the other practitioners in the area have success rates on this website here called SART, the Society for Assisted Reproductive Technology. So you can go to www.sart.org and then understand what our pregnancy rates are in different age groups, but also understand what our competitors' pregnancy rates are. So we encourage you to go there to learn more about how that might impact you, and of course encourage you to come for a consult to help us figure out what the cause is, to help us figure out if there's any female issues we need to deal with, and then ways to move forward. Here we are in 2021, of course, and we now have 5 offices. We really believe that high-end pregnancy rates, to be in the top tier pregnancy rates within the United States for IVF, requires a top-tier lab, which is a significant financial investment that takes a lot of time to monitor and assess and to manage along the way. And so our model, which is what gives us the pregnancy rates that you see, comes from having one central lab that really is going to outperform, and then having satellite offices out where you live so that 95% of your visits can be done at a satellite or regional office, where then the main office can help you when it comes time to pregnancy. So, if you lived in Myrtle Beach or Savannah or Lexington or Somerville, you could do everything in your local office with only one trip to Charleston, that being for the egg retrieval. Often the transfer can be done at your local regional office. And so we encourage you to go to the pregnancy rates and kind of look at those. We are here to help you. We have a big belief that your dreams matter, and we want to help you with your dreams coming true. And so with that, a consultation would help us figure out really what the cause is, help you understand what the prognosis is, if there's any simpler forms of treatment. About 60% of all of our patients do conceive with simpler forms of treatment. So we're not a center that's going to rush you into fancy forms of treatment. We're always looking for simple, and if simple works, simple is great. If simple doesn't work, we've got you covered with fancier treatment if that's necessary. If you're interested in being seen, we generally do a 1-hour new patient visit. About half of that visit is kind of going over your history. The second half of your visit is talking about testing and treatment options. We generally do an ultrasound during that visit. If you think you have male factor infertility, we recommend a sperm count before the visit so that we can discuss it in detail at the visit. And during that visit, we would help assess egg quality to understand the two things that matter the most, kind of egg quality and sperm quality. We'd love to see if you have questions. Phone number at our office is 843-883-5800. And then I have Holly here to give me any questions that we have. And Holly says we have a question from the audience. And the question is, do we recommend any supplements for men with male factor infertility? Which is actually a very good question. We know that for women trying to get pregnant, we do think prenatal vitamins adds a benefit. It gives them folic acid, which seems to lower the risk of birth defects that we call neurotube defects. There have been many studies looking for men with male factor infertility as whether or not supplements are beneficial. And as of this date, it does not appear that supplements are a benefit. That there have been many studies on this. It seems to make it so that it doesn't improve sperm counts. It doesn't improve fertility. We would recommend that you control the things you can control. We think if there's any obesity involved, lowering your weight would be beneficial. We think you shouldn't be on any bodybuilding hormones, no testosterone or any bodybuilding hormones. We think you should be eating a regular diet. Probably for a male, drinking less than 14 glasses of alcohol per week. No tobacco use, no marijuana use. Those would be the things that you can do to make things the best that they can be. I think that's it for our questions. I've enjoyed spending time with you guys today. I hope you are well. If you need anything or need us, we would love to help you. Feel free to give us a call. Take care. Have a good week. Bye-bye.